Right, good morning, everyone. My name is Kai. I'm a foot and ankle surgeon from Singapore. So for those of you who don't know, Singapore is a little tiny island in the middle of Southeast Asia. And I'll talk about ankle malunion today. Right, so I'm a simple surgeon. I'm a simple foot and ankle surgeon, so we're going to change a bit. I know everybody has got their heads full of angles and difficult things and coras and all that. So we're going to go with something simpler, a bit something about malleolar fractures. Right. So bone healing in a non-anatomical position, that's the definition of malunion. But of course, they come in different shapes and sizes. So we'll talk a little bit more. In malleolar fractures, malunion can occur from between 5 to 35%, depending, and it's much more common than we think. But the sequelae can be quite important because many of these are young patients, and they end up with pain, stiffness, arthritis, instability, and so on. Now, we also know that ankle fracture outcomes are directly related to the quality of the reduction. Biomechanically, there have been many studies showing that Taylor shift, etc., is associated with increase in contact pressures. So obviously, that's the classic study by Ramsey in 1976, showing the 1 millimeter Taylor shift associated with decrease in contact area by 40%. And also that we can see the graph that the contact pressures increase as the Taylor contact area decreases. And subsequently, there have been other studies as well showing fibular shortening, rotation, etc., can all result in increase in contact pressures as well. So not just biomechanically, clinically as well, there's many studies, increasing studies showing that functional outcomes following ankle fractures are directly related to the quality of reduction. And these are just some examples. So clearly, it's important to have a well-reduced ankle following a malleolar fracture. Now, the risk factors for poor reduction are many, all right, including fracture complexity, the age of the patient, osteoporosis, open fractures, non-operative management can result in a mal-reduced ankle fracture, right? But as much as we would like to blame the fracture, injury factors, patient factors, blame the anesthetist, but the truth is that many times there's also technical problems. Problems with assessment, visualization of the fracture, the actual surgery, the reduction, adequacy of fixation, and the post-operative care. Fortunately, there are also studies that show that correction of the malalignment can improve outcomes in these patients. And in this example, we have this study that shows that in a long-term follow-up of more than 20 years, when they kind of corrected the malalignment around the fibula and the ankle, the results were good to excellent even after a long time, even with minor osteoarthritic changes. And subsequently, there have been several other studies that show the same. Right, so when we look at malleolar fractures, and this is taken from Stefan Rammelt from Germany, and he has described them in 4 different types, so lateral malleolars, the medial malleolars, posterior malleolars, we've heard a lot about in the last 5 or 10 years, and also now a bit about anterior malleolars as well, where the attachment of the AITFL is. And in the assessment of the reduction of the malleolar fractures, we often look at some of these things. So fibular length. So on this X-ray, you can see this is taken from Weber's article in 1981, and it talked about the dime sign, that's number 1. Number 2, the Weber's nose, or the Shenton line of the ankle. And number 3, the medial clear space, which should be equivalent to the superior clear space. So these are all factors in the reduction which show you that you have a well-reduced ankle. We also look at medial stability, medial clear space or stress, posterior talar subluxation, syndesmotic rel reduction, so that syndesmotic instability as well as tibial plafond impaction, and these are all things that need to be assessed and reduced if necessary. So if we look at this case, we've got a 30-year-old male who fell off a bicycle. He's got a pretty nasty looking ankle there. So there's a kind of a trimalleolar equivalent. He's got a lateral malleolus fracture, posterior malleolus is subluxed. It's a large widened medial clear space. Initial reduction in the cast looks okay. CT was done, showing a Mason 2B type of posterior malleolar fracture. And this was done during surgery. So the posterior malleolus was fixed. The surgeon elected to use a fibular nail. Seems to a bit of subtle widening of the medial clear space on the fluoroscopy, but that was left alone. It was deemed to be stable enough. 2 weeks later, it looks like this. So clearly, it's not stable enough. And when a repeat CT was done, the posterior malleolus was well fixed and reduced, but the fibula was shortened, okay, and as well as a slight lateral subluxation of the malreduction of the fibula. So the patient was brought back to theater. All right, the nail was removed, the fibula was reduced again, and brought out to length. But a stress test showed that there was still instability. So syndesmosis was reduced and tightrope was put in, and thereafter that was stable. So no medial repair needed to be done. Most of the time, with a good lateral buttress of the fibula and a repair of the syndesmosis, deltoid repair is not necessary. All right, 6 months later, he's pain-free and back to sports. So in this case, we can see that the fibular length, medial stability, and syndesmotic instability were not restored during the initial surgery, and that led to subluxation and poor kind of alignment in the end. So again, brings us back to Weber's article on assessment of fibular length, and these are the indices that we should be looking at. Dime sign, again, Shenton line, and the medial clear space. So the next case, we have another lady. She fell down the stairs. Pretty nasty looking ankle again. She was put in an external fixator. All right, a CT shows, again, a 2B type of posterior malleolus fracture. So in this case, it's interesting because the surgeon had chosen to save a lot of fluoroscopic images so we can see exactly what went wrong. So he chose to fix the fibula first. Fibula was clamped, brought out to length, fixed. Unfortunately, we can see that on the clamps and on the subsequent plating, we can see that the plate obscures the articular step at the posterior malleolus. It's done plenty of x-rays, but you can't really see the posterior articular reduction at the end of the day. So this was accepted because of indirect reduction. But 6 months later, the ankle is still painful and stiff. We don't know if it's because there's just too much metal inside. There's more metal than bone now. And clearly, you can't see the posterior malleolus at all in these x-rays. So a CT was done, shows that there was a 3 millimeter step in the posterior articular surface. The syndesmosis is mal-reduced. There's a bit of plate impingement right there. And if you look at that, there's a 3 millimeter step there. There's sclerosis on the talar dome and edge loading kind of at where that step is. And we can see that that's clearly something that's going on there. So the talar is slightly posteriorly subluxed. There was a loading right at the edge of the articular step and the syndesmotic malreduction. So again, she was brought back. Hardware was removed, and we used a K-wire to localize where the step is, put an osteotomy down. All right, reduce that fragment and plate it. All right, it's just done. All right, the post-operative CT shows that the syndesmosis is now reduced. There's no more plate impingement there, and the articular surface is well reduced. Okay. And the next one, we have this lady who tripped while playing golf. She's had 7 weeks after her fixation. This was done. So we can see that in these x-rays alone, we can already see that the fibula is short. The posterior malleolus is not reduced. There's a widened medial clear space. And the CT is clear that the syndesmosis is definitely out. There's a large articular step there. So if we look at that, fibular length is off. Talar is subluxed posteriorly. The syndesmosis is mal-reduced. Again, similar problems. So at 7 weeks, it's partially united. So what we did was we took the old implants out, osteotomized through the old fracture site, brought the fibula out to length. Okay, reduced the posterior malleolus. And the syndesmosis actually was reduced after that. So there's no syndesmotic fixation required. And 8 weeks, she's able to walk, doesn't have much pain. Okay. This next one, a low energy injury. He actually just twisted his ankle while walking on a beach. All right. I don't have the injury films, but he came with a back slap. He's been casted for a couple of weeks. Looks quite all right. Reduction doesn't look too bad. Some people might might treat this conservatively in a 70-year-old, but it's quite active. So I think in the UK we talk a lot about the AIM trial and how many of these fractures can be managed non-operatively. So I think was it Professor Sharma? Would you fix this ankle fracture? No. Yeah. So in any case, in my unit, we do CTs for all these ankle fractures. So clearly the syndesmosis is out. All right. And I think, it's arguable whether it would make a difference for this patient, but he was quite active. And we can see also that there's a bit of a avulsion in front, as well as a posterior. So you can see that there's a posterior malleolus avulsion type, as well as a bit of a wax stuff fragment in front. So the syndesmosis is quite unstable. And we had a discussion with the patient. We elected to go ahead and fix it because the syndesmosis is unstable. So this was done for him. And he was well and walking in 2 weeks after surgery with a boot. So in the elderly patients, sometimes if you fix them, they can get mobilized much earlier, and that's helpful for them as well. Okay. This 18-year-old lady, she's a student. She was a pillion rider on a motorbike, and that skidded at a fairly low speed. She was casted for 4 weeks because she was overseas, and she came to see us when she was back in Singapore. So on the initial films, it doesn't look too bad. When we do a CT, we can see that there's a significant tibial plafond impaction there. So this was more difficult to recognize on plain radiographs. If we don't pick this up, it's easy to either leave it alone or fix the medial malleolus without a direct reduction of the articular surface. Sometimes we just base on X-rays or fluoroscopy, and this can be missed. So if this is picked up, it can be disimpacted, bone grafted, and fixed back. And there she is 3 months after surgery. It's more or less healed. She's back to light exercise and not much pain. So there was a tibial plafond impaction, which can easily be missed. So again, many of these were picked up fairly early. All right, and we know that if there's not much degenerative changes, we can still improve the outcomes by taking down whatever is done, and we can get a good outcome at the end, even at the long term. But how about the group of patients who then present late? All right, so definitely there'll be some. So this 28-year-old lady, 4 years after an ankle ORIF, it's complete loss of the joint space. She's got severe ankle arthritis. She's got pain, difficulty walking. She's quite young, so options are limited. Do we want to fuse her, take it down, do a debridement? What can we do? So for her, we chose to do an ankle distraction with a frame. All right, and 1 year after the distraction, she's actually walking. She still has a bit of pain, but at least she's okay with her daily activities, fairly sedentary life, but she's happy with the outcome because she still has an ankle joint. And in this other patient, older patient, he's got a renal transplant, he's on immunosuppressants, he's got a bunch of comorbidities. He had an ankle fracture 3 years ago, but because of all these problems, he was managed conservatively. But now he's got increasing ankle instability and pain. We can see that ankle is in varus, this clinical picture. He's also a bit shortened on the left side. And that's the X-ray. So there's a severely malunited ankle fracture with destruction of the joint. That's gone. And for this patient, because the deformity was fairly rigid by the time he saw me, I used a frame to get him back out to length and then fuse his ankle. All right. So he's walking on this. He hasn't had a frame taken off yet. So we're waiting on the final outcome. All right. And one more. Just I think the last case. This is Lady salesperson, she missed a step and fell while wearing heels. She's got a trimalleolar fracture. Posterior malleolus wasn't fixed. You can see that floating somewhere up there. All right, so obviously not the best fixation. She ended up with synostosis. So a year later, the implants were removed due to prominence. By this point, she didn't want anything else done. She was doing kind of okay, a bit of aching pains, but she didn't want to have any further surgeries. And 8 years later, she's actually still all right. So it just goes to show it's better to be lucky than good. Right, so just a recap. We're going to look at malleolar fractures. These are the things to assess. These are the important things to look at when before fixing. We should assess all these things. After fixation, all these should be assessed to make sure that your reduction and your fixation has been all right. And I think there should be because many patients are young, many patients are still very active. There should be a fairly low threshold to intervene again. Should we find that these fractures have not been well reduced, or if they're malunited, but we pick them up at an early stage. Because sometimes, if you sit on them, tell them we manage it conservatively, we'll wait 6 months, do some physio, the articular incongruency, the instability doesn't go away on its own. And then they end up with post-traumatic arthritis at the age of 30, and you're scratching your head wondering what to do with them. All right, so in summary, we can say that malreduction directly affects the outcome in ankle fractures. I would say nowadays we will liberal use of CT for assessment to pick up especially syndesmotic injuries, articular incongruencies, posterior malleolus fractures. If we pick them up early, osteotomies and anatomic reduction can result in very good outcomes. For those who come in late with arthritis, we have salvage procedures, distractions, fusions, replacements even. And these are the options that we have right now. All right, so thank you very much. So I'd like to invite everybody as well, come to Singapore. We've got a foot and ankle conference at the end of the year. Asian Federation of Foot and Ankle Surgeons, a good excuse to come explore the region. Please sign up if you want to.
Nice QR code.
QR code is there, that's right.
Bimanual ankle fracture is quite common injury, and you're suggesting CT scan evaluation, obviously for all of them, but because I don't know about the others, but we don't do CT scan for these kind of acceptable reduction non-displaced fractures. And just wanted to know, since you do this very much, how percentages did you get from CT scan things like tibial plateau impaction was relevant in comparison to vast majority of undisplaced fractures?
So I think there's literature out there that shows that a CT scan in ankle fractures changes the treatment plan up to 40% or 50% of the time. So a lot of times we'll pick up syndesmotic instability, we can pick up posterior malleolar fractures, avulsions that indicate syndesmotic instability, articular incongruencies. And these are things that maybe you may get away with it some of the time, but sometimes you wonder why even ankle fractures that seem to be well reduced end up with post-traumatic arthritis. And I think some of this is the answer. The reason is that we are probably missing some of this that end up with post-traumatic OA maybe 3 or 5 years down the road. And sometimes you wonder why, but because nothing was done early on, we don't know. So of course, not every patient may have access to a CT scan. Not everybody has resources to scan everybody. All right, and certainly it also depends on the functional demands of the patient. In an elderly patient who's fairly sedentary, it might be a discussion as to whether or not, what appears to be well reduced on X-ray actually needs any further investigation.
Any other questions? Yeah, one over there. Hi, Gauri. It will wake up.
There we go.
Yeah.
Hi, thank you. That was very interesting talk. I just wanted to ask, the fixation of posterior mal fragments. So we have gone through a trend of where a lot of them are being fixed. And then recently, the post-fix trial from, I think it's Netherlands, that was just published, I think last month or this month, which has again shed some different light to the matter that outcomes or short-term outcomes in fixation of posterior mal fragments do not lead to better outcomes. And in fact, from what I read, the OA rate was also not dissimilar between the two groups. So in the room, what is the general consensus for fixation of medium-sized or the ones that are less than 25? Is it if they are initially in a dislocated position, you'd fix them? Or is it that you'll fix them anyway? Or what's your approach?
So Kai, would you fix every posterior malleolus fracture under 25% of the...
So I CT all of them, and if they are completely undisplaced and small, that means avulsion type fragments. Usually, sometimes you would just you put a syndesmotic fixation to secure them, and that might be fine. But those that have articular extension with articular step, I think they ought to be fixed, because if you have an articular incongruency, then that predisposes you to OA. So as with all trials, there are the post-fix trial as well. It's just it does shed a bit more light on the matter. Maybe not all of them need to be fixed, but as always, it's a bit controversial and it's a bit of patient selection as well. Oftentimes I personally find that actually I use a posterior lateral approach, for example, to fix my ankle fractures. The posterior malleolus is there. I can fix it directly, and also I prefer to use posterior lateral plating for my fibula because there's less implant prominence, so it all works out. Because the same incision, it doesn't mean I have an extra incision. It doesn't mean I have a lot extra dissection as well. And it also reduces the rate that you need to put in a syndesmotic fixation, which means that there are less problems with that as well.
Nick, yeah? Oh, follow-up question.
No, with the syndesmotic fixation, you'd go do that through the posterolateral approach as well, as in go around through your anterior window, or how? Did you say you do a syndesmotic fixation?
You can do it through the same approach, yeah.
Okay.
Yeah, because you can dissect another window.
Okay. Thanks.
Thanks. Some fantastic cases there. Thanks very much. I was just wondering about your protocol for distraction. How long do you keep them distracted? And then what do you do with them when you take their frame off in terms of weight bearing and protection?
Yeah, so with the distraction, they are weight bearing through the period of distraction. I keep the frame on for 3 months. So initially in the OR, I probably get up to about 2 or 3 millimeters of distraction, and then after that I do a millimeter a day. And I think there are some studies that show that on a non-weight bearing film, you probably need 7 millimeters of clear space to be adequate distraction. On a weight bearing film, you need about 6 so that you have no contact pressures on the joint. I think between the hinge and non-hinge type is about the same. So sometimes if I'm short of time, then I just do a static distraction. And that seems to work quite well. So after 3 months, when I take them off, I usually put them in a boot for about a month because they can be quite uncomfortable initially. Once the frame comes off, so they're in a boot for about a month, and after that I kind of wean them off. And then gradually increase. They get physio immediately once they come off the frame, and I get them to aggressively do range of motion exercises and all. Yeah, I do.
Action patients?
So I think I started off scoping a couple of them, and but I think to try and just to remove some of the bone spurs and do a bit of colectomy and things like that. But I found that there's actually not much difference whether you do it or not. So unless they are large impinging spurs, otherwise if they're just small ones, I don't scope them.
Question at the back, yeah.
Given your access to CT scan, do you routinely get CTs postoperatively to assess your syndesmosis reduction? And a second question is, do you repair superficial deltoid? And if it's not routinely, who do you do it on?
So I do a routine post-op CT for my patients. All right, all the ankle fractures get pre and post-op CTs. And for the, sorry, what was your other question again? Oh yeah, that's right, yeah. So I usually test them. So if they come in with a large widened medial clear space, after I've done the fixation, I will do a vulgar stress test to see whether the clear space opens up a lot. If it's stable, I don't do it. So I think I've repaired the deltoid probably less than 10 times in my career.
Kai, for those without access to CT, weight-bearing X-rays?
Yeah, I mean, I guess that's the next best thing. But the truth is that I think CT has been a game changer for a lot of these ankles. So if you can do get them, especially, I mean, if you had to prioritize some, then definitely the trimalleolar fractures get the CT. All right, but there's also we're also picking up a lot more of these avulsion type fractures and things like that on the CTs for bimalleolar fractures. So there's the field is still quite rapidly changing, and there's a lot of things coming up that show us, because obviously the CT means that also we are being overly sensitive and picking up a lot of things which may not need fixation. All right, but then that remains to be seen what needs to be fixed and what doesn't.